Hello, I'm your host, Bev Muendel-Atherstone, the chair of Lethbridge Friends of Medicare. Today we are joined by our guest, Karen Collin. Welcome, Karen.
Hello.
Karen has worked for decades as an RN, and she's worked in the U.S. healthcare system, which is quite interesting for us today, with our Premier wanting to make our healthcare a lot like the U.S. system. So thanks so much for joining us here today.
You're welcome.
So Karen, you were an RN in the U.S. What took you there?
Well, I was younger, quite a bit younger, and I realized that I liked working in different places. I had worked across Canada in several provinces, BC, Alberta, Saskatchewan, Newfoundland, and I thought, oh, I'll try the U.S. In the 80s and 90s, a lot of nurses did go to the U.S.,
Yes.
and I thought I would try it and took a travel nurse position in California.
Oh, California.
Yeah, outside of Los Angeles.
Oh, I'm from California.
Oh, there you go.
Yeah, but from the north.
Oh,
So you had worked previously in Canada in healthcare?
yes. I had a few years experience. And I thought, well, this would be something different, and just, I wanted to see Disneyland, of course, and all the other sites that are around in Los Angeles and that area. I've never been.
Fun area. So your training as a RN was here in Canada?
Yes, I trained at the Royal Alexandra Hospital in Edmonton.
Oh, yes.
Did a 3-year nursing program, and then I worked for 10 years in nursing various places across Canada, and then I ended up in Lethbridge and took my post-basic RN degree, so post-basic Bachelor of Nursing degree at the University of Lethbridge, so 2 more years of training there.
Oh, good for you. So I understand that you are now retired.
Yes, I'm retired. I retired a little early because health issues come, so you have to change your life plan a little bit.
That's right. Well, so what brought you back to Lethbridge?
Job. I came back here. I had worked in different places, and then I'd come back to Lethbridge, took my degree, and decided to do this travel nurse job, and then came back because family was here by then. And there were various things that family needed help with, so I came and stayed here. And I worked here in Lethbridge, actually at St. Michael's Hospital, when it was still the hospital with the emergency and everything.
Yeah.
And when the regional was just beginning to change into the new regional.
So you know quite a bit of the history of Lethbridge and our hospitals, and you've got a big picture of Canada and the U.S. It's lovely to have that parallel knowledge. So we want to focus today on what actually happens in private for-profit systems that is different from a public health care system. And it seems like you have that kind of knowledge. So were you working in a private for-profit or a public system or a mixed system in the U.S.?
It's a little hard to answer because it's a while ago, but I believe that it was basically kind of a mixed one, because you needed to have the right insurance company in order to be in that hospital, and you also needed ability to pay for quite a bit of your care as well. But it was a big hospital. I will say that the hospital was very nice, clean, well built, had all the things that you would need. It was quite big though, which I wasn't used to. I'd been in smaller hospitals in Canada, but it was a nice hospital. However, it was difficult to work in that kind of setting. It's quite different, the kind of care you give when people are paying for things versus here, where if you need your dressing changed here in the hospital, nobody says, don't do that, I can't afford those gauze sponges on the tray. Whereas there, people would say, no, don't change my dressing because that's going to cost me too much.
So how did that impact you as a healthcare person? How was that for you?
It's really difficult. The reason the U.S. likes Canadian trained nurses is they're well-trained nurses and give really good care. I will say that for the majority of nurses in Canada, give really good care. And so if somebody needed a dressing change, you change that dressing. If somebody needed skin care, you do it. I was used to, for instance, with seniors, every 2 hours you give them skin care, reposition them, give them fluids and so on. But you cannot do that when the person has to pay every time you do that. And you would see patients suffering because they couldn't afford the cost that, and I had to write down on a little card that I had at the bedside everything that I did, like two bandages, to whatever, turn them when that was, if I gave skincare, whatever, and then that went on the computer, and then that would go to the insurance company for the costs. And then the patient has to pay, obviously, some of the costs. Insurance doesn't cover everything.
So even being turned
Yeah, it's costly.
is costly.
Yes.
So everything that happened in terms of the care you pay for, whether it's a Band-Aid, a bandage, a sponge,
Yeah.
antibiotic, it's all being...
It's all recorded and costed out by the insurance company, and of course the patient gets a big bill as well, but the insurance decides what they're going to cover out of that hospital bill.
How did you find that impacted your time for personal care versus when you were in Canada?
Well, I found it like there was so much administrative part to that, because I had to carry this big file with everybody's patient card on, and then I'm trying to take care of them, but I have to write everything down as well, and I have to count how many little gauzes I use, or how many, pieces of tape, whatever it was. And so then you're doing that, but then you have to take it and go to the computer. You have to enter that as well there.
Oh, you had to do the computer entry.
Yes. And even things like, okay, if my patient needed a blood transfusion, then I have to go to the computer and I have to order that. Then they notify me when it's ready. And then I have to go across the hospital to the lab and get it, and then come back and then find another nurse to check it with me, and then I can go give the blood to the person. Meantime, the patients that I'm taking care of don't have anybody there. So it was very different than here. Very different.
How was it when you were here?
Well, here, you would call the lab and I'd say, I need blood for this person. And they would say, okay, and then they would call you saying, we've got it ready, are you ready? And you say, yes, they'd bring it up. So I never had to leave the patient's side, and never had to, ignore my other patients, so to speak.
So it actually took time away from care of patients.
Yes.
This additional administration and putting it in the computer.
Yes, yeah.
So
There's a lot more paperwork. Although nowadays, I've recent experience with someone in hospital, they have a little handheld computer and they have their ID bracelet with their little square on it. I'm not all that fond of that either, because I felt like there's a mismatch between, are you actually looking at that person to see who they are and what they need and what you're giving. But that's where medicine is now, apparently.
yes, I was going to ask you about the little handheld computers and other ways of tracking that are done in some hospitals, but I've heard in some of the hospitals, even here in Lethbridge, that not all of the computer systems are compatible.
Yeah, there can be that trouble, but apparently it's all going to, it's got a name, Patient First or something, I never remember the names, but I don't know. I don't like to be identified by a barcode. And the other problem is, when I was, like I said, with a friend recently in hospital, the computer system was down. So she couldn't get a pain pill because they couldn't, check her barcode, and they couldn't do the computer. Well, to me, that's a big risk. I think there's benefits to technology, but you need to be aware of the other side. We're dealing with people, not machines. And you can't tell the patient, well, just wait till the system's up again and then we can help you.
So because the system was down, she couldn't even get a pain pill.
No.
Because they couldn't identify her on her bracelet that was computer linked.
Yes, yeah, you're barcoded.
Now, we've heard, being in Canada, we know that litigation is huge. In the US, you get sued for just about everything. So what was it like being an RN and someone says to you, I don't want this bandage changed, but then they get an infection. So how does that impact you as the RN?
It's really a fine line, because you're having to talk people into something, because you say to them, like, we really have to do this because, for instance, you get an infection or something like that. So we must do this for your health, and trying to talk them into it at the same time as you realize it's going to cost them, and maybe they can't afford that big bill. I just felt like I wasn't taking care of people the way they should be taken care of. And my job as a nurse is to help them get better, whatever that may look like. It doesn't mean that people don't die from natural death or whatever, but my job is to help patients be comfortable, be cared for, and as far as possible get well. And you can't do that when you have to count every little dressing or not do something for them or not even give them like a package of tissues or something, because it will cost. It's just, to me, not okay.
So when you had this discussion with the patient saying, you know, I really should change this bandage, you could get an infection or whatever, then you would have to chart that you had the conversation.
You'd have to write something to say that, you know, patient refused at this time, something like that, so that it was known that you did offer something. It's similar though, I mean, it really is similar in Canada, although patients in general don't refuse treatment that way, but you do have to record somehow what you've done all the time. I mean, I didn't come in the computer era where everything was on the computer, but we had to chart on every patient, every shift, even if you were working, say, long-term care and nothing really was different. You have to chart something about them and sign your name so they knew you had observed them and that that was a legal record, so your signature and so on was there. Any medical record of anybody can be called up at any time in a court of law, and you need to be sure that you have your correct signature and your correct information. So even if they do refuse care in Canada, you write that in the details, but you do try and take care of it so they don't have to refuse care.
So the charting, there's charting in both countries.
Yes.
But the main difference was the increased time in writing down everything for the insurance.
Yes.
So that could be tracked and then charged for.
Yes, yes. I think the other part about insurance that people don't realize is that that determines where you go, what treatment you can get, which doctors you can see. All of that is determined by your insurance company and coverage. So I needed to go to a walk-in a couple times when I was there, and here you go to a walk-in clinic, no problem, right? Alberta Health, whatever. But there, I had to go to a walk-in that my insurance company was covered, plus I had to show my credit card to make sure I could pay for that. So you can't go to the wrong walk-in. You also don't have a choice about doctors or hospitals. You have to go to the one the insurance company says. And the insurance company determines also whether you can have certain treatment. So if you want to have like certain surgery and this insurance company can say no because that's too big of a cost for them or it's too risky under their legal parameters or whatever, so you can be denied care. I mean, you can, in a way, be denied care here in Canada as well because of long wait times and whatnot, or it's only that surgery's only done in certain provinces or whatever. But you still can, access care of some sort, but it's all based on the insurance company.
So there's levels of care within the insurances. So the amount that you pay and the kind of insurance that you buy, whether it's sort of the gold standard, platinum gold,
Yeah.
silver standard, bronze, on down to no insurance whatsoever. So did your hospital take care of the people who didn't have any insurance?
On the unit that I worked on, I think everybody did, but one thing I did see several times when I was working there was a vehicle would drive up to the front entrance, and out of the doors of the vehicle would be an elderly person put on the sidewalk, and then the car drove away. And the reason was they couldn't afford the care of that person. And I saw it several times. It's like...
So the car would drive up to the hospital,
drop the person off and
drop
leave.
the person off.
And that person would have no ID on them, so that way this family wouldn't be caught, so to speak. But they had no choices because they didn't have money.
So then this person would be cared for at the hospital?
Well, then they'd call a social worker and so on and so forth, and that person would have been put somewhere. They weren't necessarily sick, but they were elderly people, the ones that I saw. And that's years ago, but we have sort of a similar situation here. People aren't refused, but people are sent out from our, for instance, emergency department who actually don't have anywhere to go. and don't have anybody who cares for them, because there's not a lot of follow-up to some of the patients who are in there.
So you're saying here in Canada,
That can-
people are sent to emergency who don't have any other place to go. Is that what you're saying?
Yeah, well,
Yes.
sometimes they end up there in emergency and they don't have any other place to go, but they get their treatment, whatever, their stitches or something, and then it's goodbye. Nobody checks, well, who's picking you up and that sort of thing. That's kind of gone by the board. I won't say all the time. I think that our emergency staff work really hard and do the best they can, but our system isn't set up to make sure that when a person comes into your building, that discharge planning starts from there, and that's how I was trained. The person, when they enter, you check what their situation is, and before they leave, you make sure that, like, they have a ride or they have somewhere to go, those sorts of things.
Someone will pick them up, something
Yeah.
like that.
They're not just
Yes.
heading out and sitting in the bus stop by the hospital, which, because I live by there, I see them sitting in the bus stop by the hospital because they don't have anywhere to go today. Or they don't have money for the bus to get downtown to go to the services.
And follow-up seems to be a big problem too. A lot of people who go to emergency in Canada are going there because they have no family doctor,
Yes.
or because they need medications, and because they have no family doctor, they can't get the medications, so they go to emergency. So right now, we have a lot of people going to emergency who otherwise would be going to primary care, and that's because we've lost so many doctors through the mean-spiritedness of our government that has scared off a lot of doctors. So there's problems in our system right now as our government is trying to force us into privatization, private health care. Now, you were mentioning something about people with pre-existing conditions and their ability to get insurance.
Well, if you have any kind of condition that isn't the ordinary thing, if you're going to get sick, like get a heart attack, everybody knows what to do with a heart attack, and you're going to get covered and you're going to get to the right things. But if you have a condition that's not so well known, then trying to find care for that is going to be difficult. I have what's called a post-viral syndrome. Okay, now we have long COVID, which is just a post-viral syndrome. I say just, but it's a big deal. But it's not a thing that has a little list that the doctor can go, okay, symptom 1 to 10, okay, that equals this, so then we give this treatment. Whereas if you come in with a heart attack, oh, you fit, you know, these are on the list, oh, that's, so then we do this, and we do this, and so on. So we're still not being open to the fact that medicine really knows about as much about the head of a pin, really, about medical things. Everybody's so individual and so different. So we really don't know that much. And so we really need to be open to the fact there's many different kinds of health conditions, and there might be many different kinds of treatments, and no one should be turned away because you don't understand, or I've not seen that before. And I personally have been told a number of times by a doctor, oh, I don't know anything about it, so I can't help you. And the other response is, oh, I don't believe in it, so I can't help you.
Oh,
So you end up trying to find a doctor who will say, well, I'll help you despite those two parts of my beliefs. I'll help you. In fact, it's a recognized health condition. Doctors are taught about it, but it's just not a big deal condition, like I said, like a heart attack. It's just not as well known, although it's, you know, like MS is the biggest thing in southern Alberta. Across the country, we have the most MS.
yes.
I have a condition called ME, and there's more people with ME than there are with MS. But you don't know what ME is.
No.
You've never heard of it. Nobody will. So I feel like going to the clinic and saying, I have MS, just change the S to an E and give me treatment. You know, but there are other people with various conditions that aren't recognized, and the fact that whether we have enough doctors or not isn't so much to me the thing. The fact is, do you have a system, because systems rotate around themselves, they're circular, they're made to keep going. Do you have a system that has enough different types of people involved in it that you can get the care you need? So I don't believe that doctors should have the only entry point to the system. I believe there's nurses, nurse practitioners, there's social workers, there's psychologists, chiropractors, physiotherapists. There are many people with many skills, and if you could get an entry into the system through one of them, because that's where your condition fits, and get the care you need, I think that our system would work better. It's always going to rotate around itself because systems do that, but there are openings for various entry points, and I think that to me is way where we should be going. Yes, you need doctors. They have specialized information, but in one area. They're one system. They have their areas of expertise, but a social worker has different ones. A speech therapist has different ones, and so on. If we utilized everybody in a clinic, such as Tabor has a clinic, where they have various specialties working together, and they have had that for years, works very well. If we use that kind of system where everybody can get the care they need, but not necessarily having to go to a doctor, we don't need then loads of doctors. We need good doctors, enough specialists, but we can still get the care we need if we don't actually need the doctor. Sometimes you don't need the doctor, you need something else, but you can't get it until you get that
So part of what backs up the system is the referral process. You have to go to the doctor to see a dermatologist, you have to go to a doctor to do this, that, and the other. Yes, and social workers are working with our unhoused population, and sometimes people who are living outside all the time end up with foot problems. And so if you have a social worker who sees the foot problem, then they could refer this person with feet problems to the appropriate facility rather than going through a doctor. Is that what you're saying?
Yes. I'll reference it to when I worked at St. Michael's. I worked in emergency there.
Okay.
And the police would sometimes bring in, we had a few people that were well known in town who were homeless. They were just unable to keep housed. They would not stay housed. But everybody knew them, and the police would bring them in once in a while on an evening shift when it wasn't too busy. And we would take that person and they would get bathed, they would get fed, we would treat whatever needed treating, new clothes, whatever, let them sleep on a stretcher in an emergency overnight, feed them in the morning, and then they would go off and live their life for another couple of weeks until they'd be brought in. And it worked very well for those few people who couldn't be housed, wouldn't stay housed, but we managed, and they managed because we did that kind of care. It's maybe not the best use of emergency, but it saved those people from getting into other problems. I remember a few of them, there were 3 or 4 of them that were like that. Did very well. It wasn't what I would have chosen for them, but that's how they lived.
So I was asking you about what Tommy Douglas wanted to institute, and that was never instituted in Canada, the prevention aspect of healthcare. And I imagine that you didn't see much of prevention in a system that charges for every single little thing.
Oh, yes. I mean, because I was in hospital setting, then I didn't know a lot of what happened outside other than, the few times that I might have to access some health care. But I did, see people who maybe weren't able to afford health care, so they would be, like they are today in Lethbridge, living on the streets, that kind of thing. And there wasn't really anywhere for them to get any care. But we do have same kind of experience here. And when I worked at St. Michael's Emergency, we did have people, some regulars, that would be brought in by the police in an evening. They lived on the street, and the police would bring them in for us to give them a bath, take care of them, new clothes, feed them, have a place to sleep overnight, feed them in the morning, and then they'd go. And there were 3 or 4 people that were what I would term regulars that would be brought in that way, and it was a kindness to them. They weren't able to be housed. They did not do well in housing and never stayed in it, but they were able to live a life because the system cared for them in a different way. But the other part of prevention, which, as we know today, is not being practiced in the U.S., it's quite negative towards things like vaccination and other kinds of things. But in Canada, we are facing a big problem with that kind of issue, and in Alberta, very, very big. And I'm old enough to have been exposed to polio, which is part of my health issues. So post-polio, it's a post-viral syndrome that happens years later. I have had measles, both kinds. There are 2 kinds. I've had mumps, I've had chicken pox, thank goodness, not whooping cough and those things, but other children did, and we grew up with those. And we were quarantined many times. Nobody made a fuss like we do here nowadays. But it was only because vaccinations were new. And like polio wasn't available till I was in grade 1. And the other immunizations, as they came on board, all the parents got their kids vaccinated. Actually, the public health nurse came to the school, September, October. Everybody lined up, you went up, held your arm, got your shot, went back to school. There was never any fuss, and no parents refused it, no children refused it, and a few teary eyes is all you ever saw. And that's made a difference why today's adults actually have never seen those things, and most doctors under 40 have never seen any of those illnesses either. But those of us who had them can tell you that they are not without risk. I've had a nephew who actually was vaccinated and who still got whooping cough at the age of 1, and for an entire year he was not able to clear from that. Then he was better, and when he was 3 he got severe asthma. He still suffers from it today, and they consider it to be from the damage that was done from whooping cough. And that was a child who was vaccinated. Imagine if he hadn't been vaccinated, what illness he would have had.
Yes, and this prevention actually is exactly what it says. It prevents people from getting worse, and for whatever is causing the difficulty, like the broken ankle or the ankle that you've stumbled on, that can cascade into like a domino effect with the ankle and then the knee and then the hip and so on. So I think we're really missing out by not having the prevention piece. We're just looking at how we can pay for health care, how people can get rich on health care, but we're not looking at the individual and the individual needs of Albertans or Canadians.
Yes, and there's kind of a circle around that as well. Like, okay, because I hurt my ankle, then there are other things that are affected. So I end up with sleep issues. So then that makes other problems because now you're overtired, so then you don't heal as well and so on. Like there's things like, for some people, a person that I knew who the home situation was not okay, could not manage, but couldn't get to the doctor because of mobility and pain and so on. So then they only had phone appointments. Well, on the phone, you can't see how that person is. Even on a computer screen, you can't. So that person just went without seeing a doctor, and just the phone appointment, they say, well, this is what's going on, and the doctor says, well, I'll send you a prescription for whatever. And this person just got so sick eventually, and this is sad to say, but eventually chose MAID, which medical assistance in dying, because just couldn't take it anymore. But the moment that person chose MAID, 2 doctors could come to the home. Social work came to the home, palliative care nurse came to the home care help came, meals came to the person. All that stuff came because of that one choice. But before that, nobody could come to the home and see what the situation was and what that person might need. Granted, that person had a very rare and difficult condition that wasn't really a treatment per se. But that was the only choice that person had to get out of the difficult situation they were in. Other people, another friend who just got really sick, was in hospital, and then their home situation wasn't okay to go home to. Ended up just, okay, here's where you're going, into a senior care place. No real choices, nobody had checked out before, and has been several years not hardly ever able to get out. So we're really missing the prevention, as you said, and changing the system to meet people's needs, and we won't need as many acute care beds in the hospital. We won't be having as many serious things happen.
Well, we've had a lovely discussion today. I know that we're going over time.
Okay.
And thank you so much for being here and for explaining your parallel lives in Canada and the US in terms of healthcare systems, because we don't have many people in Canada who really know intimately what the situation is in the US. And people are often missing out on the thinking that if I can just get private health care and I can get to the front of the line, I can get my knee or hip replaced, I'll be in great shape. But they're not realizing the costs that this will entail ultimately for the whole healthcare system, that when we go into that privatized system, we'll be looking at an entirely different system.
Yes.
And mentality. The mentality will not be patients first.
No.
The mentality will be money first.
Yes.
Thank you so much, Karen. It's
Thanks
been
for
delightful.
having me.
Yes, thank you.
It's been fun. Thank you.
Thank you.